Let's get to our next guest, Dr. Bridge Bombay, for the Centric Health Hour. He's, of course, a physician owner of Bakersfield Heart Hospital. He comes on every week. So we try to really understand this virus and what it means for us, not only today, but in 3 months and maybe even 3 years. How long are we going to be dealing with this? Dr. Bridge Bombay, welcome, sir. How are you?
Well, Richard, how are you?
I'm terrific. For some reason, Dr. Bombay, I'm feeling optimistic about the number of people who, I know we still have supply chain issues with the vaccine, but we're moving in that direction. And I'm feeling much more optimistic about, the cases are down but I don't want to get I don't want to get over my skis here. What say you? Are we turning the corner on this thing, or could we be if we did something stupid on a Valentine's Day weekend, really set us back?
I share your optimistic message. Given the fact that we have roughly 27 million people who've been exposed to the virus, another similar number, if not larger, who were asymptomatic, and throw in 30 plus million who have the vaccination, you're creating a pool of about 80 to 100 million people who potentially have the immunity to the virus. And that creates a significant hurdle for the virus to infect others. So we are, I would say, at least halfway there in terms of herd immunity. It doesn't disallow the spread of the virus, but it slows it. So I kind of concur with your assessment that we may have turned the corner on the worst possible outcomes. But that doesn't, as you astutely outlined, that doesn't give us the right to seek another super spreading event.
Right.
Hopefully the Super Bowl didn't do that. And we don't lower our guard, because the virus is still out there in plenty. Maybe the damage will be somewhat contained, but that doesn't mean it can't get out of control.
Yeah. There was a CDC report yesterday, Dr. Bombay, which said, among other things, that if you have had both the doses of the vaccine, that you would no longer have to quarantine if you were exposed to somebody who had the active virus. But then they went on to say, but you have to be careful after 90 days. And I heard that and I thought, does this mean that I know we've talked about booster shots and maybe that's going to be in our future forever or whatever, but does the vaccine does it start to wear off after 90 days?
I think a lot of those things, what CDC comes up with, some experts sit in the room and come up with the recommendations. But the logic dictates, based on our past experiences with other SARS viruses and infection with COVID-19, that the immunity should be longer lasting. One hopes certainly no less than a year, but it could be a 2-year thing or even longer than that. So the recommendation that there isn't any need to quarantine if you've been fully vaccinated is appropriate one. I don't know where the 90 days number comes from, and it doesn't seem to have a basis in the facts.
Okay, well that's good. Yeah. What about if you are, these vaccines are only, say, 95% effective or whatever. If you've had both vaccines and you can still contract the virus, does it follow logic that the COVID case you're going to have is going to be less severe?
So that's a very good question, because even in South African strain, what we have noticed is the efficacy of the vaccine is reduced in terms of possibility of infection occurring, but the infection is tuned down from severe to mild to moderate.
Okay.
The two important hard endpoints are hospitalization and death. So even the Johnson & Johnson and the Novavax vaccines in South Africa eliminated death and hospitalization, because at the end of the day, that's what you don't want.
Right.
So even a reduced efficacy is a very effective efficacy, and that's a take-home message that necessary for people to recognize that. Don't argue with the name brand. Any vaccine is a good vaccine.
Interesting. Well, that's encouraging to hear. When I hear, and you're the expert. I'm not. But when I hear about these variants from Brazil and South Africa and England and wherever else, and it doesn't take them long because it's a small world, and they pop up here. Are we? And as this virus stays and continues to mutate, are we in a race to make sure that we get, is this a race to get to herd immunity before you end up with a strain that we're going to have to start all over with?
This is the main concern, that it is a two-part answer. First, pertinent to USA. A couple of things that have happened today is that they're expanding the access for vaccination centers. The pharmacies are being recruited, and I still am at loss why the physician offices are not recruited, because that, to me, is the most logical place, because physicians know a patient, they know their comorbidities, they know how to risk stratify a patient. And if a patient has vaccine hesitancy, the physician is the right person to talk to them and share the necessity for it. So I think they are making a small effort towards expanding the vaccination centers to the pharmacies, which I'm very happy about. But they should also expand it to all the physicians so we can overcome the vaccine hesitancy and more appropriately use the vaccine. Yes, the race is there. Go ahead.
Well, I just don't understand why you guys are the experts. You brought this up last week. Why we're using Dodger Stadium and the Kern County Fairgrounds when we have all these practicing physicians who have relationships with their patients and know how to contact them. And are you saying that it's still other than your urgent care? Well, I know you're giving it at the hospital, but what are they not doing that you would want them to do?
Well, I have no idea. It makes eminent sense. Richard, at the end of the day, I don't care if it's method or madness. The end goal is vaccination, because a vaccinated human is protected and protects others. So I don't care if they vaccinate in Dodger Stadium through madness or through doctors' offices through a method. Get it under. But the rollout should happen through physician offices and pharmacies, which is the commonsensical way of approaching it. And we have an abundance of resources that can be put to use in a very efficient manner, as opposed to reproducing in temporary setups like Dodger Stadium and other places.
Right. So, and as we start to get, I believe the percentage I read, they said that in California, almost 11% of the population has received at least one dose. And I think 3.6% has received both, if that is accurate. Are we starting to see, is it starting to manifest itself, people who are reluctant to take the virus, or they talk about African Americans being reluctant because of the Tuskegee experiments and some of the long memories of that? Where are we with that? Do you have a handle on how many people just may opt out?
There are two categories of people out there. One are vaccine hunters, and the others are vaccine hesitants, the extremists. So people who are really worried about the virus are finding every way possible to look for a place where they can get the vaccine and break the line. And then there are vaccine hesitancy for obviously the Tuskegee experiment, lack of trust with the government. And in my practice, because I deal mostly with the sicker element of the society who have multiple problems, diabetes, high blood pressure, heart issues, I find compliance to be nearly 90%. So the people, even when they're hesitant, it's easy to sell them, hey guys, it makes sense. I did it myself. I wouldn't expose myself to unnecessary hazards if I didn't believe in the science and the necessity of it. and people see the merit of that argument. And that's why the physician offices, I continue to say, are the best places to both advocate for it and administer it. But I do find that one subsegment of the population that has resistance is elderly black people who sometimes have struggled, and most of those conversations are said, oh, okay, doc, give me a couple of months, let me think about it.
Yeah, right.
So that's where the vaccine hesitancy is most abundant at. And Richard, another thing we should also recognize, and the point has been made repeatedly, that people who get the COVID and die from it are mostly African Americans and Hispanics.
Wow.
African Americans 4 times as much, Hispanics similarly so. And another subset of people who are excessively likely to be infected and have an adverse outcomes are people with dementia. And when you combine dementia, age, and African American, you really amp up the risks of death and divorce.
You mentioned these high-risk groups, Hispanics and African Americans. Are you pleased with the way the vaccine is being rolled out? Do you think it's being rolled out in an equitable way in which people in those communities have equal access to it?
I think it's a good question again. If it was through the physician offices, it would be equitable. What it is because the demand-supply equation is disturbed. The people with more resources make more efforts. Anybody who's reluctant or doesn't have the access to internet, that creates an artificial, a real impediment. It's not an intentioned impediment against colored people.
Yeah.
It's just that the people at the lower, the socioeconomic section of the society have lesser resources. So it's not accessible to them because of the place in society they have. So it's not malicious. It is just the way the society is.
Oh, that's interesting. When we have bandied about some numbers on what does herd immunity look like, do you have a percentage? Is it? I think that you had said several weeks ago it was like 80% or 75%. What does that look like?
That's a moving number and depends upon the contagiousness of the virus. More contagious it gets, higher the number necessary for the herd immunity. But I think 80% would be a good target for us to achieve.
Okay. What about, are there any new developments in treating the vaccine, any new protocols, or, how are we treating it with the people who get it? Have we advanced on that?
So there are different experiments out there. One is, when is the best time to give this booster dose? And we discussed it previously also. The reason Pfizer had 3-week separation and the Moderna had 4-week separation is because of the compulsions of the pandemic. They tried to bring the booster dose closer to the initial dose. But you could easily stretch it to 6 weeks or 8 weeks and actually have a better booster, better anamnestic reaction or a better booster response. So to increase the people vaccinated with the first shot and delaying the second shot is a good idea. Second component is mixing and matching. So one person gets Pfizer, the other gets Moderna. That experiment is being conducted because to stick to the same protocol at times becomes a logistical challenge. Third thing is people who've had COVID infection. Do we vaccinate them? How long after the infection? And what is the protocol? And I have always felt that there is no reason to immunize people who are naturally immunized with COVID infection for at least 6 months. And there's no reason to give them 2 dosages because they already have an abundance of immunity from the previous infection and they just need 1 booster dose. And today, France actually made exactly the same recommendations that following COVID, we should wait for 3 to 6 months and there is no reason to give second, just 1 booster dose. So these are all those logistical developments which I think are progressive in our effort to immunize more people in a quicker, more efficient manner.
Right. What do you, and final question here, Dr. Bombi, you're talking to Dr. Bridge Bombi of Centric Health. Talk about what do you think if, I think the Biden administration said that they would hope to get you hope to reach herd immunity by June or July or whatever, and a lot of, at that point, then there's going to be plenty of vaccines for everybody. We talked about this earlier, but can we expect that either for this COVID-19 or maybe another variant that we're going to be getting some kind of like a flu shot, like a booster shot every year?
That's a conceivable outcome. And that's why, because when we, first of all, it's very encouraging that we have a substantial access to the supply side, so we won't be hurting for the supplies. We already have 600 million shots reserved. But that's only in the USA, and we all recognize that virus anywhere is virus everywhere. Yeah. And if people get infected in other parts of the world, the virus has an opportunity to create mutants, and if those mutants are able to escape the previous immunity, you will be compelled to have additional booster dosages, and the virus keeps the ability to come and reinfect. And that's why universal vaccination, not in the country but in the world, is necessary. And there's a program called COVAX, which a previous administration wasn't part of, but the Biden administration is part of. To me, it's extremely important that the vaccination is made available to poor people in the rest of the world, because when we vaccinate those people, it's not an act of charity. It's our self-defense. And
right.
We need to recognize that.
Oh, wow. That's what the COVAX program is? Is it a program to make sure the whole world is vaccinated?
That's right. So multiple countries in the world have joined forces in an effort to make sure there's a universal vaccination.
Okay, very good. Okay, we're out of time. Dr. Bridge Bombi, always a great segment with you, sir. I hope you have a good weekend. I hope you stay safe. Hope you do something special on Valentine's Day. But, of course, I hope you stay safe, sir. Thank you for coming on.
Similarly so. Stay safe and have fun. Thank you.
Okay, buddy. Thank you. All right, 2:20.